Our keynote this morning is Dr. Ben Sommers, and we're fortunate to have him right in our backyard. He is a professor of health policy and economics over at the Harvard School of Public Health. His work in the area of health policy focuses on vulnerable populations, uninsured populations, as well as the healthcare safety net. He's also a practicing physician here at the Brigham and Women's Hospital in Boston with an appointment at Harvard Medical School. And his research has received numerous national awards, and in his history, he was also an advisor to, a senior advisor to the U.S. Department of Health and Human Services. So let's warm welcome for Ben Sommers.
Good morning. Let's see, I'm going to move around a little bit. There we go. Make sure I stay awake, you stay awake in the midst of very technical discussion around health insurance and the big changes coming in the United States over the next few years. I'm going to try to map what we might see happen to what we know about the past decade of health insurance change, what that means for the workers' compensation landscape over the coming years. First, I just want to acknowledge the research funding through a variety of different organizations that have supported our team's work over the years, and acknowledge, as Ramona mentioned, that I have previous experience working in the U.S. Department of Health and Human Services, but this work and this talk fully represent my own view and not the department's. So, what are we going to talk about today? First, I want to lay the landscape of where we are in terms of two programs, Medicaid and the Affordable Care Act marketplaces. I want to track where we've gone over the past decade, which will be familiar, I think, to many of you, but just a kind of high-level view of how we got to where we are. What do we know about the impacts of these policies and these large programs? And then we're going to turn to what's ahead, with a particular focus on the new legislation passed last year, the One Big Beautiful Bill Act, as well as some of the other changes that are done not through legislation, but are through oversight through the Trump administration and the federal government's regulatory role. We'll talk about employment and health. There's an interesting intersection, a really important intersection to understand related to the policies that are coming, including work requirements, most notably. And this has important implications for workers' compensation to be thinking about not only the health of workers, but whether anyone is working and who's in that employee pool. Finally, we'll tie that kind of together with some of the research findings, including some of the work done by WCRI, that gives us some insight as to how do we map these potential changes in coverage to what might play out in the workers' comp space. Okay. Couple quick slides, basic background, level the playing field for everybody who's, some of you probably think about this all the time and some of you probably haven't thought about this ever, or at least only once in a while when you see a news article on it. We're going to go through the basics real quick on Medicaid expansion and the Affordable Care Act marketplaces to understand what has happened and what's going to change in the next few years. The Affordable Care Act expanded eligibility to adults with incomes under 138% of the poverty level. It's about $21,000 plus change for a single person in 2025, roughly double that for a family of four. And the really important thing to remember and understand about this is it's not just that the level of income that you needed to qualify for Medicaid got more generous, but that's part of what you're seeing here, that dashed red line showing you now that's where we lifted the eligibility level up to with the Affordable Care Act. The other really important thing to note is before 2014, before the Affordable Care Act expansion took effect, in most states in the country, if you did not have a child living at home and didn't have a disability, it didn't matter how poor you were, you couldn't qualify for Medicaid. Because you not only needed a low income, you also needed to have a pathway of eligibility, a category of eligibility. What you see on this graph here is now the median income cutoff depending on whether the state has chosen to expand Medicaid under the ACA. For kids, it's much more generous. Medicaid covers children up to 255% of poverty on average. For pregnancy, we see the coverage is up to just over 200%, and that includes both pregnancy and a little bit of the postpartum period. And then for parents, this is one of the key points, is that yes, parents of dependent children can qualify for Medicaid if their incomes are low. But before the Affordable Care Act expansion, you had to be quite poor. In fact, you had to have an income on average less than half of the federal poverty level. What that means is if you were a parent and you were working but you didn't have enough hours to get above to get above the poverty level, you could still be considered too rich for Medicaid in many states in the US. Now, with the Affordable Care Act, that level comes up to that dashed red line at that 138% of poverty. But if the states that have not expanded, and I'm going to give you an updated number, that 24 is not right, because we're down to 10 states that haven't expanded. When we get down to around half of the poverty levels, what you need to qualify as a low-income parent. But meanwhile, it's even starker if you are someone whose kids either grew up or don't have any kids who live at home. Because now in most states, with really only one exception, which is congratulations, Milwaukee, for joining our enterprise here. Wisconsin is the one exception, which is a non-expansion state that does cover some of these adults without kids at home. But in general, it doesn't matter how poor you are. You cannot qualify in the remaining non-expansion states. Okay. So what does the map look like as of now? I've been updating this map every year for my classes that I teach. I haven't updated in a couple of years because there's been no movement since the end of 2023. Right now we have 40 states, including Washington, D.C., that runs its own separate Medicaid program, that have expanded the Medicaid program under the Affordable Care Act. 10 states have not. Those are the ones here in red, and you see they're clustered in the South primarily. And then the most recent change was in North Carolina, and that was now over 2 years ago. So we haven't seen much movement recently. This is going to be really important when we start looking at the changes coming under the One Big Beautiful Bill Act, because a lot of those provisions treat states differently depending on whether they expanded. The Affordable Care Act originally envisioned all states would expand Medicaid. That was how the law was written, but the Supreme Court in 2012 made it a state option, and this is the landscape that has resulted. Okay, so that's a really big part of the coverage story for the Affordable Care Act. But the other big part is the creation of the health insurance marketplaces. The idea here was, what about people whose income is too high for Medicaid, even with this new expanded set of criteria, but they don't get coverage through work? A lot of these folks are self-employed or they work in small business, and they don't have coverage that they can either offered through work or they can't afford their offer. The marketplaces created a centralized location for people to do their shopping online. The idea was something like Kayak or Expedia to make it really easy to see side by side what your offerings were. The law also changed the rules of the game for those insurance companies. They could no longer charge different prices based on health status. They could no longer have pre-existing condition exclusions. If you applied, all you had to input in terms of your premium was your age, where you lived, and whether you smoked. So those criteria made it easier for people to see their options, but it was still going to be unaffordable without additional support. And so the ACA also included premium tax credits, which were essentially discounts at the point of purchase based on your income that made coverage more affordable. That set of subsidies existed for the first 7 years of this program, but in 2021, during the pandemic, Congress passed and President Biden signed into law major expansion of those tax credits, making them much more generous. And in fact, what the result in some of the work that our team at HHS analyzed in 2022 was that of people who had no health insurance but could go online and qualify for these tax credits, 60% of them could actually find a plan for $0 a month, depending on what coverage they picked. So these enhanced subsidies and expanded subsidies made a big difference. As we'll talk about shortly, they expired at the end of 2025. Congress likes to pass things with a time limit because it makes the price tag smaller. I think the people who passed it thought it would keep getting extended, but it didn't. And so there have been big changes in terms of the premium tax credits available to people in 2026. And that's had cascading effects on the premiums even without the subsidies, because insurers know that this is going to change their case mix, right? They're going to see different enrollees, they're going to see fewer enrollees, and in particular, they're worried they're going to see fewer healthier enrollees. And so that has led to premium increases. The other thing that was going on during in terms of the marketplace in the last several years was the Biden administration ramped up significantly how much money they spent on outreach, informing people about their options, helping them navigate and sign up. And this led to some of the largest gains in coverage in the past decade. Okay, so a couple graphs here, some small print. I'll walk you through them. The line here on the left side of the screen is showing you the percentage of the population that has no health insurance. So this is the uninsured rate for the country. And you can see that it pretty much was flat for the decade before the Affordable Care Act, toggles up and down a little bit, generally with the economy. When things are better, more people have work, more people have coverage through work, and then it goes down during recessions. But the big drop happens in 2014, in that first light blue bar that says ACA takes effect. This is the Medicaid expansion, initially in 25 states and now up to 40, and the creation of those marketplaces with the marketplace tax credits. Big drop in the uninsured rate. That line over 3 years goes from about 14% to around 9%. And it's about 20 million more Americans with health insurance during that period. Things kind of flatten out for a little bit. There's a slight uptick in 2019. I'll talk more about this in a few moments. This relates to some of the non-legislative tools that the administration controls, and there was a lot less advertising, a lot less outreach going on in that period during the first Trump administration, and what we see is a slight tick up in the uninsured rate. Then 2021 hits, pandemic, a bunch of policies, including those enhanced subsidies, and the uninsured rate starts to come back down again. And in fact, by late 2022, 2023, the uninsured rate was the lowest it had ever been in the US. We still had about 8% without health insurance, about 26 million people with no coverage. For those of you who don't spend time thinking about the international context, that's unique. Other countries don't have this, right? We are really the only high-income country that has tens of millions of people without health insurance. But this was the lowest it had ever been in the US in terms of the percent of the population. What was the driving factor of the type of coverage people got? Well, that's what the orange and blue bars here on the bottom right are showing you. 2014 was the first year of the ACA expansion. Each of these bars is telling you the total number of people gaining coverage through an Affordable Care Act related program. It's about 12 million in that first year. About half of that is marketplace and half of that is some form or another of Medicaid. That number jumps up in the first couple of years. It takes a little while for these programs to take hold. So that's why we see in 2015 and 2016 the number goes up significantly. More people understand the program and sign up for it. Things level out for several years. And then in the 2021, 22, 23, bigger subsidies, a few more states expand Medicaid, and more outreach going on, making it easier for people to sign up. And we hit 40 million, basically, 40 million people whose coverage is in some way attributable to the Affordable Care Act. All right. So what? Now, I know in this audience, a lot of the focus is, well, you care a lot about who's covered because it's going to impact claims. It's going to impact the overall kind of economic function of the country, as well as employers and workers' comp. But I work in the School of Public Health, and we also care about what's the overall health impact. And it turns out that the Affordable Care Act provided a really important way for us to understand the impacts of health insurance. If you go back about 10 or 15 years, it was really an open question of whether having health insurance improved your health. There was the common sense answer, well, of course it does, but in terms of hard evidence, we didn't have much. And so the Affordable Care Act created this patchwork of different state approaches, some states expanding, some states not, some states more aggressively getting people covered than others. And this has been an opportunity for us to really understand what happens when you give people health insurance. Well, the first thing is people feel better. If you ask them, are you in good health, are you in poor health? When people have health insurance, they're much more likely to tell you that they're in good health. This is true in a bunch of different studies, whether you're looking at some of the states that went early before the Affordable Care Act in expanding Medicaid. Here in Massachusetts, we had something that some people refer to as Romney Care, when then Governor Mitt Romney led Massachusetts health reform, which ultimately became the model for the Affordable Care Act. The Affordable Care Act also let people stay on their parents' plans. Young adults could stay on their parents' plans up till age 26, sometimes referred to as the dependent coverage provision. And then we just talked about the marketplace and the Medicaid expansions. In all of those studies, people felt better when they got coverage. They told you they felt better. Now, that's not just subjective. It's not just their opinion. First off, I'll say as a primary care doctor, I spend a lot of my time trying to help people feel better. And if they tell me they feel better, I believe them, right? That's part of my job, is to take at face value if somebody tells you that their health is improving or not. But it turns out that this simple question, are you in good health, fair health, poor health, actually predicts mortality. If you follow people who tell you they're in poor health, they die at much higher rates and much younger ages than people who tell you they're in excellent health. So that's encouraging. And it turns out that when we then track the effects of the Affordable Care Act, we see that people do, in fact, live longer. We see fewer preventable deaths happening from causes of things like diabetes and cancers that can be screened and heart disease that can be treated. So we have an increasing number of different studies that show these mortality benefits. Now, not every study shows it. You have to kind of take the overall body of evidence. And my take, and I think of several other researchers who have written about this recently, have kind of put together a bunch of these studies and said, we now have pretty good evidence. And let me tell you just a hint of what that looks like. The first is a series of papers our team did looking at some of those early Medicaid expansions, which showed not only declines in mortality, but that this was actually a cost-effective way to do it. You do spend more money to cover more people. Sometimes you'll hear people say, hey, if we get more people insured, we're just going to save society a lot of money. We'll keep them out of the emergency room. That's not true. It's a nice idea. It would be great if it were true. It's not. It turns out people use more health care, but that's probably why they're getting better. And so view this as an investment, right? It's not a cost-saving tool. It's a way of investing in people's health and at a fairly low cost compared to other things we do, helping people live longer. Studies looked nationally at the Affordable Care Act Medicaid expansion have shown reductions in cardiovascular mortality in expansion states compared to what was happening in non-expansion states. Census data show that if you focus in on people who gain Medicaid under the ACA, we see declines in premature death, particularly in the 55 to 64-year-old age group. And then I think most convincing is this really interesting study where the IRS, the US Treasury, sent out postcards to everybody who didn't have health insurance and said, hey, remember you got to sign up for coverage or you have to pay this tax penalty. This was back in the days of the mandate penalty. Well, they actually ran out of money and couldn't send the postcard to everybody. So they had to randomly decide who would get the postcard. And they sent it to about 4 million people, and about 1 million people they had on their list didn't get that postcard. And what they found was that postcard reminder, that nudge to get coverage, led a few percent more each year to sign up. And then really interestingly, when they followed them over time, they saw that the people who got that nudge were less likely to die in the following year. And this was a randomized trial, big randomized trial. So pretty good evidence here. Giving people health insurance is going to improve health. Okay, so that's where we've been. Big coverage gains, Medicaid marketplace, improving population health. Where are we going? On the marketplace side, the second Trump administration has implemented a couple of things right off the bat that didn't take Congress acting. The first was they cut significantly the amount of spending on outreach, advertising, telling people about the marketplace, telling them about healthcare.gov, telling them that it's time to go sign up. They shortened the open enrollment period. The period of time that you can sign up for the marketplace isn't year-round. Right? You have to sign up during that end-of-year open enrollment unless you have a qualifying life event. And the administration shortened that period. And most recently, we heard the administration announce plans to encourage more people to sign up for very high deductible catastrophic plans. Now, this hasn't been finalized. This is a proposed rule, but they're looking to do things like allow catastrophic plans that continue for several years of enrollment. People can sign up for once and have it go on for several years. Some of these deductibles could be tens of thousands of dollars, and so really not much coverage unless you get, as the name says, catastrophically ill. And this also is proposed to be available to a broader range of the population. The Affordable Care Act limited catastrophic plans only to young adults, but this would make it available across the age range. The other big changes that have happened involve Congress. So the first here is the expiration of those enhanced premium tax credits. Now, this wasn't something that anyone actively did. It was something that Congress didn't do. I told you Congress extended those subsidies through the end of 2025. Well, if you don't extend it after that, they just go away on their own. And that's what happened. There was a government shutdown in the fall. Democrats said we're not going to open the government unless we can add these subsidies back in and extend them again, but there weren't enough votes to do that, and so the subsidies went away. We're already seeing very large increases in premiums this year as a result, and starting to see some of the early indications that people are dropping coverage. We won't know the full extent of that for a little while because it actually takes several months before most people lose their coverage if they don't pay their premium. But at least 1 million so far, fewer than last year, and that number might get significantly higher. And finally, the One Big Beautiful Bill Act, which I'll be talking more about in a second on Medicaid, changed some of the eligibility-related criteria for immigrants. Now, undocumented immigrants have never been eligible for these programs, and they remain ineligible. But there are certain groups that are legal permanent status. For instance, people who have a green card but have a certain income range that used to be able to sign up for the marketplace and no longer will be able to, as well as people who qualify as refugees or asylees who have legal status, who are protected groups based on their experience of persecution. They also will no longer be eligible for marketplace subsidies. Okay, on the Medicaid side, what's happening? First, work requirements. We're going to talk a lot about that, so I won't spend too much time on it right here, but it'll come back in a few moments. Also, increased number of eligibility checks. Medicaid is not permanent coverage, right? You sign up, you have to show you're eligible. You have to then redetermine that eligibility. Under the ACA, it was once a year. But now it's going to be every 6 months for people who are enrolled through the Medicaid expansion. That's going to take effect starting in the end of this year, in December 31st, 2026. There's also going to be more cost sharing in Medicaid for people with incomes above the federal poverty level. In some cases up to $35 per service, with various protected categories of care that are not allowed to have copays. And finally, there are changes to how states are allowed to finance their Medicaid programs. Medicaid is run with a combination of federal dollars and state dollars, and the states now face additional restrictions on how they raise money to pay their share. Okay, so let's dive into these a little bit more and get a sense of what these changes mean. I told you the enhanced subsidies expired as of December 2025. There doesn't really appear to be much appetite right now in Congress to extend them, given that there was a prolonged shutdown where this was the core issue and it still didn't lead to extension. I think it's unlikely to happen this year. Could it happen? It could. You could see a partial expansion, who knows? But my guess is most likely these won't be extended if they haven't already been extended yet. Depending on the numbers you look at, the Congressional Budget Office, some of the independent organizations that study this, our team has looked at this, probably 3 to 4 million people who could lose their insurance and become uninsured as a result of the higher premiums that they'll face. And then the other changes we talked about are non-legislative changes. These are kind of rules and oversight from the federal government. 90% reduction in navigator spending. Well, navigators are organizations and community groups that help people sign up for marketplaces, help them understand their options, look at the plans, and pick one. And then I just briefly spoke about the catastrophic plans becoming more available. And the reason this matters, it's not just the fact, yes, if you cut subsidies, fewer people will sign up. That's fairly standard economics, and yes, that is what seems to be happening. But some of the other work that our team has done, and I believe John Gruber was a previous keynote speaker here and also has done work with WCRI. John and I have done a bunch of papers over the years looking at the Affordable Care Act, and this is a study we are in the process of finishing up, led by a PhD student, Gabby Abalafia. And what the three of us were looking at is how effective is the ACA at getting people covered, and how does that vary based on who's overseeing the program? And we basically have two punchlines. The first is the same law, without any change in what Congress has said, can be more or less effective depending on who's running the federal government, and that the Trump administration, in its efforts to reduce outreach and offer more non-standard plans that have higher cost sharing and higher deductibles, actually reduced enrollment significantly compared to the Biden and Obama administrations. Now, it depends on your perspective if you think that's a good or a bad thing. If you think that covering people and improving their health and spending money to do that is worthwhile, then you think you would like to see more investment there. If you think that there's a lot of fraud in the marketplace, if you think this is money the government could spend elsewhere, you might say, well, I'm okay with fewer people being covered. But what's clear from our research is that it matters, even without Congress passing a new law. And the other thing we find is that the national landscape depends greatly on state leadership as well. If you live in a state that has set up its own marketplace and uses its own policies to do outreach and get people enrolled or to discourage that enrollment, you actually can get widely different enrollment numbers. And what we find is basically the same dollar amount of subsidy is twice as effective in the states that have chosen to run their own marketplace in terms of getting people covered and reducing the uninsured rate compared to those states that rely on healthcare.gov. A lot of the recent discussion we're hearing out of Washington is, well, if we don't extend those subsidies, maybe what we ought to do is find other ways to improve affordability, and there's been a lot of focus on health savings accounts. We can talk more about this in the discussion Q&A if folks are interested in it. Most of the policy analysis I've seen suggests this is probably not going to make a big difference. If you can't afford premiums, it doesn't really matter whether that coverage has a health savings account or not, right? If it's just too expensive for you, it's not the nature of the coverage, it's whether you have it. Health savings accounts are pretty good if you have a high income and have a high marginal tax bracket that you're getting to offset as deductible. But for families that are really struggling with affordability of care, this is probably not going to be a panacea. And I mentioned some of the immigration-related policies. The upshot here is just to know that there are several groups that have legal status that used to be able to get covered and now are not going to have that option. including asylees, refugees, and some people with green cards. Undocumented immigrants have always been ineligible for these programs, and they continue to be ineligible for these programs. There's sometimes a red herring where they say, well, what we're really trying to do is change these programs to make sure undocumented immigrants don't get covered. Well, they're not allowed to get covered, so that hasn't changed. Now, there is one program that gets a little bit of attention called emergency Medicaid. This is money that gets sent directly to hospitals if they have to provide emergency care or inpatient care, regardless of immigration status, because hospitals can't turn people away. It's not comprehensive insurance. It doesn't follow the patient. It's really just to the hospital in that case of emergency. The One Big Beautiful Bill Act, OB3, as I'll call it for short, did reduce some of the federal dollars coming into the emergency Medicaid program. This is a pretty small share of the program. It's 0.4% of national spending. So this is not going to make or break the bank in terms of Medicaid dollars, but it is a wrinkle that sometimes gets, I think, outsized attention. And if you look at the overall effect of the ACA, what you see is it benefited both groups, citizens and non-citizens. Now, it's really important here, non-citizen does not equal undocumented, right? The majority of non-citizens in the US do have legal status. They're either legal residents, some of them are, again, refugees, or they have a green card. And so there were big gains in coverage because this group started at a 50% uninsured rate, right? A lot of these folks, most of these folks are working, disproportionately in jobs that don't offer insurance. Right, if they're in service jobs, if they're in agriculture, they don't get coverage through work. The ACA offered a pathway to that coverage. So this is kind of some of what we should expect to see a reversal of with these changes. All right, and I'm going to try to get to our discussion in the next 5 minutes here. So let me talk briefly about some of the big Medicaid changes. So states are paying some share, depending on the state, of their program. It ranges. The Mississippi, for instance, gets the most generous federal support because it has the lowest per capita income. High-income states like New York, Massachusetts, California only get 50% of their Medicaid spending reimbursed by the government, and they have to pick up the other half. A lot of states do that in part using something called provider taxes, where they charge taxes to healthcare entities like hospitals, nursing homes, managed care plans. They tax them, and then they use that to fund part of their share of the Medicaid program. The One Big Beautiful Bill Act restricts how much states can do that, and particularly does that restriction in expansion states, where they will have less ability to raise money this way. And the argument is that states shouldn't be able to take with one hand, hand back with the other hand. On the other hand, the state Medicaid programs will tell you, well, this is the way that they funded their program for decades, and without it, they couldn't really have a program, or at least it would look a lot different. So we'll see, this is going to put a lot of pressure on those 40 expansion states. Now, not all of them use provider taxes, but most do, and they're going to hit that cap. All right, finally, last few minutes I want to talk about work requirements. These are also called community engagement requirements, and it is very simple. You want to get Medicaid, you have to work or be doing something else to show in community engagement. This is a very popular provision if you poll the general public without a whole lot of extra detail and you just explain, here's the policy. Most people say, yeah, that sounds like a good idea, and that includes Democrats and Republicans. Now, the issue is you have to implement it, and I'm going to show you some of the evidence on what it means to implement this. The folks who propose these and advocate for work requirements have said, hey, this is going to help lift people out of poverty. We're going to give them that nudge to go work. We're going to build self-sufficiency. We'll get them into employer plans instead of public Medicaid plans, and that's going to save the federal government and state government money. All of these things could have big impacts on workers' compensation, right? If we get more people to work, if we see more people shifting from one type of coverage to another, if we're improving their health, all of those things could affect workers' comp. The One Big Beautiful Bill adds this federal work requirement for the first time in Medicaid, and it does it in the 40 expansion states. It will start at the end of this year, although a couple of states have talked about starting earlier, mid-2026. Many activities can qualify, 80 hours of work, community service, being in school, caring for a disabled family member. And then there are a lot of groups that are also exempted. If you're pregnant, if you have a disability or a serious medical condition, medical frailty is the category that's described in the law. If you're being treated for substance use disorder, you're exempted. Okay. So this is a really important area where we have to understand what the law intends versus what we actually know how it operationalizes. The work requirements that the ACA or the OB3 implement meet these criteria, and we have something pretty similar to this that we can compare to understand what it's going to do, which was in 2018, Arkansas got special permission to try something very similar. They required 30 to 49-year-olds in Medicaid to meet their community engagement requirements, And when they started this program, within a couple of months, 18,000 people had been removed for non-compliance. And I'll show you in a minute what that means. It's a substantial increase in uninsured rates that resulted. It wasn't just that people moved from Medicaid into private coverage. What we see is most of them became uninsured. We studied this by looking at people in Arkansas and some neighboring states to see what happened before and after. Well, uninsured rates went up. We saw no change in employment, and a third of the people who were subject to the policy said they'd never heard of it. Obviously, if you haven't heard of it, it's not going to change your behavior. This graph's kind of complicated. The only part that I really want to focus on here is this first set of bars. This is the 30 to 49-year-olds in Arkansas who were subject to this policy. About 40% were already working, a little more than 40% were already working. The yellow group had health-related limitations that kept them from working. Medicaid has a lot of folks with disabilities and major health problems. Of the remainder, there's some who are looking for work or jobs, there's some who are students or in community service. Only that narrow sliver at the top, the red, 3.3%, 3.9%, those are the folks who weren't meeting criteria one way or the other. Basically, most people in Medicaid either work or have a good reason not to work, and the small number who aren't, that's the group that you're trying to get with this policy. And the problem is that 3 to 4% that you could induce to work, you're making 97% of other people jump through all the hoops to show that what they're already doing meets the criteria. And what we found in our study was a lot of them didn't. A lot of them didn't meet those criteria or couldn't navigate the system, even though they should have been able to keep their coverage. Because of this, studies like ours have informed estimates that 5 to 6 million people could lose Medicaid due to the red tape of these work requirements. And the Congressional Budget Office predicted there would be no impact on employment. This isn't actually going to get more people to work. It's just going to create a lot of burdens to staying enrolled. One of the key issues is how much of that people have to report themselves, how much paperwork they have to fill out versus what the state is able to ascertain behind the scenes. And this is really important because if the state can show that you're eligible with the data they already have, because they have your state income tax data, or they have an unemployment claim, or they know that you have a medical problem or substance use disorder, they shouldn't make you fill out any paperwork. They should be able to say you meet these criteria, and the law actually requires that. But states really differ in how well they can do this sort of thing. And I'm going to wrap up by showing you a little bit of evidence on something that happened during the pandemic that relates directly to this. During the pandemic, states were required to keep people enrolled in Medicaid. They couldn't disenroll them during the public health emergency. And this was called the continuous coverage provision. This went from basically the spring of the pandemic through April of 2023. And at that point, then states had to go through and redetermine everybody's eligibility for their program after 3 years where they didn't do it. And what happened was 24 million people lost coverage during this so-called unwinding of the continuous coverage provision. When you look here at this work that was led by my colleague Adriana McIntyre, what these bars are telling you is what share of the Medicaid program was removed during that 1 year period. And so you can see some states, at the far left, for instance, Maine and Oregon, under 10% of people were removed from the program because most people were still eligible, most people kept the coverage. But meanwhile, if you go all the way to the right, you can look at Utah and Oklahoma. Those bars are really high, right? 40 to 50% are losing coverage. Here's the interesting thing. Only the orange bar at the top are the people who are actually found ineligible for the program. The rest of that, the blue, that dark blue, those are folks who didn't complete the process, who couldn't get through the paperwork of the system. Now, did some of them lose insurance because some of them not do the paperwork because they knew they had other coverage? Maybe, right? But when you see the gap between Maine and Oklahoma from like 2% losing coverage because they didn't fill out the paperwork to like 45%, that says systems are difficult for people to navigate, right? Think about filing your state income tax, but instead of doing it once a year, you're getting to do it twice or 3 times a year, right? Think about getting to fill out a driver's license application, go to the RMV 4 times a year. Does that sound fun? Right? These are the sorts of things we're talking about. And if the state knows that you're eligible and they do it automatically behind the scenes, you can get most people who are still eligible stay in the program. And if you don't do that and people have to navigate these systems, we can see large numbers who are eligible who become uninsured. Okay. How does all this affect workers' comp? When people have insurance coverage from other sources, we often see claim shifting, right? So some of the studies that have been done on this show, for instance, in Massachusetts, when coverage was expanded, there was a 5 to 10% reduction in workers' comp paid claims in the emergency department and the inpatient side. In reverse, when we see what happens when young adults age off their parents' plan at age 26, we see an increase in workers' comp claims as people enter that age group where they're less likely to have outside insurance. And even if you don't lose coverage, if it's just that the coverage changes, it increases cost sharing, for instance, like we see is going to happen in Medicaid under the One Big Beautiful Bill, or if more people sign up for catastrophic plans because the administration is pushing that, what you can see is that many workers are going to preferentially start using workers' comp for their claims because otherwise they're exposed to large out-of-pocket costs. One study that was, a couple studies here cited by the Institute, show that high deductible plan growth in the employer market has actually led to 1 to 3% more spending on workers' comp in the decade of the 2010s. All right, so I'm going to wrap up there. Went over a little longer than I meant to. I got excited, I'm sorry. But looking forward to hearing discussion and talking with Ramona and getting some audience input as well. The big take-home messages, the Affordable Care Act and Medicaid expansion improved access to care, financial security, and health. People got healthier, people felt better. The coverage gains from this past decade are going to partially reverse under some of these changes like work requirements and the reduced outreach and premium subsidies. The workers' comp spillovers, both from fewer people covered and changes in the type of coverage people have. Unlikely to see big shifts in employment, however, even though the work requirements are a key part of this, just based on prior literature, most of the folks in this population who can work are already working. And finally, there are some tools that states have. The more states can do behind the scenes with automation and data matching, the fewer eligible people who will likely lose coverage, and that's going to matter a lot for understanding the impacts of this law. So I'm going to sit down and we'll go to the discussion and questions.